Hello and welcome to MEPcast, a podcast for maternity education program of Clinical Skills Development Service. In each episode, we explore ideas and issues on how we can enhance and improve the delivery of maternity care education.
Every day in Queensland, midwives and obstetric medical officers make a difference to the lives of consumers and their families who access the Queensland health facilities. Not only do they influence the consumers they care for, but they teach and support student midwives and medical students to become a future for midwifery and obstetrics. Healthcare workers make a difference for what we do every day and have an impact on everyone they are in contact with. With that comes a lot of responsibility, but maternity is a great place to work. My name is Sue Hampton. I'm your host today. And I'm a midwifery educator here at CSDS. I am a registered nurse and midwife with over 40 years of experience in healthcare. Today, I'm going to be discussing how human factors affect our day-to-day working environment and how it relates particularly in emergency situations and our working environment. This will give us an understanding of why we feel the way we do and hopefully give you some strategies on how we can improve our performances and deal with situations in the healthcare environment. I'd like to welcome my guest today, and that's Dr. Mia McLanders. Hi, Mia.
Hi, Sue.
She is a human factors researcher working at CSDS and is affiliated with the University of Queensland. And she's going to share with us some information around human factors, which we have in healthcare, which some of you may be aware of, and how that affects our performance, how we can learn to cope with situations related to human factors, and why education and training help us to perform in our healthcare environments. So thank you again, Mia, for joining us. I've really looked forward to this afternoon, and hopefully we'll have a good discussion. I know when we've talked before, we both are on the same page with this. I'd just like to ask you a couple of questions really to start off, if you wouldn't mind.
Sure.
Can you explain to the listeners exactly what is meant by human factors?
Definitely. So, Sue, human factors is really about understanding our human capabilities. So it's things like our perception, our attention, our memory, and we use this, our thinking processes as well. And we use our understanding of these internal human processes for the purpose of designing our equipment, tools, our systems, and even the way that we perform our clinical work.
So that's really interesting. So do we actually do a lot of that sort of things where we actually design things around human factors nowadays? Is that how it's done?
It's improving. I think in North America there's a lot of focus and emphasis and an appreciation of how important it is to understand as human beings that we interact with the tools within our workplace, and that really can affect our outcomes and our even the patient experience, patient outcomes as well. And so it's something that's growing in both awareness and also implementation within clinical settings. Human factors is often sort of used in healthcare at the moment as sort of a euphemism for human error. So it's something where we say, oh, the human factors got in the way. But in actual fact, when we talk about human factors, we are very much talking about at a systems level, and we're looking at improving systems that do support better work processes, so more of the things that we want to see, and help us to be resilient when things don't go according to plan.
So really what you're saying is that, we've always really incorporated this in our day-to-day work, but we haven't really realised that we were doing it. But now we study it in a much deeper, much more depth to gain much more insight into what actually affects the care we provide.
Absolutely. And it has very much, human factors is a scientific discipline of, it's the science of people at work. So it's empirically based. We do research and we do, well-designed empirical studies to support the things that we know to improve the way that we perform the work that we do.
So, Mia, tell me, what made you choose human factors research? Why did you get into this in the first place?
Yeah, I think it was probably 2012 that I first sort of became aware of human factors as a discipline. And I was drawn to it because I think it has very much the ability with very minor changes, and as a researcher, I find that sometimes the work that we can do can be quite abstract from being practical and being very applied. And I think human factors is a very applied discipline, and it's also, we have the ability to make small changes to things that can have really big and life-saving consequences. So my first exposure to human factors In fact, the very first study that I did in 2013, I designed and executed under supervision was around designing a clinical form. And I know that in that study, we found a significant improvement in the way that people were reading the dosage of a particular medication that has fairly serious consequences if there's mismanagement or inappropriate dosages given. So right there, I was able to see that, just design A versus design B, we could read, the using human factors principles to design a clinical form. We could improve both the time it takes to actually look up a dose, but more importantly, that we're actually looking up the most that it is the accurate dose that we're looking up.
So can you just tell us of some other, you've just touched on something that you've been involved in, but what else have you been involved in which relates obviously to the human factors, which has actually changed practice? Other things that you might have done, which I know you have been involved in quite a few things.
Yeah, I think most recently, and probably the one that most people would be familiar with, would be the QADS patient monitoring charts. So that's work that was started back in 2010, which was before I was involved, and there's been an enormous amount of research done on that. But I've come in more recently and been advising on the layout and the changes of the QADS form. I was also involved last year in the validation study with the University of Chicago, where we ran 220,000 patient data.
That's a lot of people.
Yeah, through the actual QADS system. And because, people get used to using the systems that they're used to, and sometimes we really need that evidence to help say, okay, well, you might be used to Form A, or in this case, patient monitoring system that you're used to using, but in actual fact, you're going to have fewer false alarms and you'll have better detection of deterioration if you're using QADS. And so we did that as a statistical analysis with the University of Chicago. So that was a very important study. I've been involved in the design of the sepsis pathway. We've developed a neurological observation form where previously sort of quite minimal in the observations of detecting neurological issues in patients. I've been working with teams doing a neurovascular observation form, so looking at lower limb, and we're in the process of starting the upper limb form as well. But the volume of my work has been very much in the space of neonates, so looking at the teamwork in neonatal resuscitation. So that's work I've been involved in at Mater since 2013. It's ongoing. I have a project ongoing at the moment where we're looking at thermal management during resuscitation and supervising a student through the completion of that work as well.
This is all really interesting, and it's having been in a clinical role fairly recently, we all have great ideas about how we can develop forms particularly, or develop some systems. How do people go about accessing somebody like you to give them some guidance? Because clinicians have great ideas, but sometimes they're maybe not the right thing, as which I've discovered talking to you about, implementing change. So how can people access people like you to help them?
So typically the way that it works is that someone will have an idea, or they'll identify a gap in their clinical practice, and then they'll come and talk to someone at patient safety level, and then they approach me and we work together to we'd like to very much do a multidisciplinary team approach. My approach is also very much a user-centered design approach, so I work very closely with clinicians to help understand, first of all, the problem that they're trying to solve, because sometimes what we think are the problems are actually the symptoms of a problem. And so getting that thorough problem identification, and then identifying where we might be able to provide solutions, and then very much doing that from a user-centered design process.
I think that's really valuable, because I think a lot of clinicians have got some fabulous ideas, and one, they never know where to start, and secondly, they're sometimes put off by the fact that they're nervous in case they don't do something in the correct way. So to have somebody like yourself, or someone in a position that you can actually apply this to, certainly I wish I had it a few years ago, and I've done some design and things that haven't worked out purely because I don't have your background. So it's really good to know that we have you around. Actually, it's fantastic.
Thank you, Sue.
You've touched on something there which obviously is very true to my heart, around neonatal resuscitation and basically emergency situations. I've always been really interested in what happens to us in emergencies. Every day in hospital maternity departments, if you work in like a birth suite environment, there's often emergencies of varying degrees. And I've always wondered how you teach and support junior colleagues, how they're able to cope with those situations, related around your human factors ideas. Yeah,
so we know that acute changes in our cortisol levels can affect our memory and attention. And but the effects of that are quite selective. So we have different levels of memory. So we have like prospective memory, so remembering to remember. Then we've got our long-term memory, short-term memory, different types of memory. So it can affect our recall. It can affect the level of attention that we're able to give to the task. It can also affect our thinking processes. The effects of stress, it can also sharpen our thinking though. So sometimes stress and cortisol can get a pretty bad rap, but it can be very useful to help sharpen our thinking, heighten our awareness. But as you say, there's an optimal level there, and in actual fact, the effects of stress on cognition depend on the type of stress, the timing of the stress, the intensity, and also the duration. And so anything that we can do to help sort of when we get past that point of optimal arousal, so yourself when you're feeling sort of stressed, but it's good because you're awake, you're ready to go, you're ready for action, but then sometimes you sort of go beyond that point and you start to sort of get cloudy thinking and starts to affect and impair your judgment, and you just can't think straight. And so I guess when we get to that point, one of the things we can do is help sort of down-regulate our system, is to focus on activating our parasympathetic nervous system. So we can do that by just implementing some breathing techniques. So, maybe lengthening our out breath shorter than making our out breath longer than our in breath, for example, is one way that we can. And
that's quite interesting you saying that, because, I've learnt my own strategies of how I deal with emergency situations. I used to be one of these people who would run to an emergency. I'd hear an emergency bell and I'd run to the emergency. But by the time I got there, I was out of breath. Hadn't had time to collect my thoughts. I'd go into a room and my adrenaline levels were so high, I actually couldn't think. Mm-hmm. So now over time, I've got a strategy where I walk fast, but I take lots of deep breaths, and I hadn't actually realised what I was actually doing. So when I'm teaching my juniors, I teach them not to run. I say, walk fast, get to the door, take a deep breath before you enter. So that's really interesting what you're saying. And I've obviously learned this because I realise it does calm me down and does make me think more clearly. And certainly some of the things you've said with regards to that foggy thinking, I think when you work in an environment where your stress levels have been high because the situation has been unfolding, it can be just the last thing that tips you over the edge. So it's a difficult one to know how to teach people that, but I think it's interesting that you're talking about how we react, how we react differently to that. I've also seen the situation people freeze. So what's that all about?
Yeah, it's a tricky one actually, and I've had a look through the literature, and there's not very much, unfortunately, there's not much attention given to the clinical reaction to the stress response, so the fight or flight response in a clinical situation from the perspective of the clinician. So I think the best advice, and I've interviewed hundreds of clinicians over the years and talked to them about what happens during emergency procedures, and I think the most important thing that I've learned from those interviews is that it's important for individuals to know their own stress response. So the way that manifests sometimes in a clinical scenario might be that, and you and I have spoken about, rushing to intervene. So, we in the neonatal space, and I know from speaking with you, Sue, in the obstetric space, that there's a natural process here. So with neonates, it's a natural processing of transition, and we're there to help and assist as needed. Sometimes when we get that very heightened stress response, it can be very tempting to rush in and do procedures that maybe if you just gave the patient a little bit of time, they would actually continue on and recover or transition in the case of a neonate without as much intervention. It's also, obviously that comes down to experience level and clinical judgment as well. But I think just being aware that stress response does influence your judgment and decision making. And so, the other alternative response obviously is where people stand back and freeze and don't really know what to do, as you say. And I think in those cases, again, awareness is the most important thing, understanding that that's what's happening, and then having strategies to go to. So it's one of the reasons that we have decision support tools, is to help support cognition during really stressful events. And so, decision support tools are literally there to support our memory and cognition. So supporting our recall and our thinking processes.
So things like your flow charts and those sort of things that are in guidelines, those are the things you're alluding to. Okay.
Absolutely. Yeah. So the resuscitation algorithm, for example. So when they're well designed, I will have to caveat with that, because there is a danger with poorly designed cognitive aids that they can actually reinforce heuristics. So that's just like a shortcut. So maybe we make a decision about what's happening for a patient. We reach for an emergency manual or a cognitive aid of some sort, and then we just continue down the pathway. And maybe we have a non-normative patient. So we have someone who has, for example, with neonates, it might be, a congenital abnormality like a diaphragmatic hernia, for example. We're following the steps of the algorithm could actually be not beneficial for that patient at all. So we need to make sure that our decision support tools support normative work, so work as it's usually done, but also non-normative case scenarios as well.
So I guess it's back to that thing that all humans are different, and we present in different ways. So it's important that the clinicians try and look at that holistic view of the person that they're dealing with, basically.
Yeah, and just making sure that you have that human factors involvement, so that you've got that broader systems perspective. So that when we're designing tools of support, that they're actually going to support you all of the time, not just some of the time.
So this is where your research comes in, because obviously you can test out those tools, I guess.
Definitely. Yeah. And what you were saying earlier about having clinicians who may be not confident around asking for help, or maybe they've got an idea, they have a solution they're wanting to trial, but they're not really confident about it. Well, I think, particularly here, we're very fortunate in the clinical skills development service that we have great simulation space. It's not just used for simulation-based training, but also for testing. So we can actually run through with tools and essentially what I like to call it like breaking them. So we try and explore and find the boundaries and limitations and the weaknesses and vulnerabilities in the processes that we have in everyday clinical practice.
And you've certainly asked, I was going to ask you a question about how, staff they work in a fast-paced environment. So how can staff give themselves some preparedness for that? And I think what you're saying there is some simple training in simulation may be good, or even in situ training may be a good idea. Because obviously exposing people to all these various different things that are out there is quite difficult from the point of view as you can't expose every clinician to every different situation.
So I think, unfortunately, the default response in healthcare is very often for more training. So if we identify, particularly through root cause analysis, or we might have some sort of a near miss or something, and the response is often that we just need to train people more. They need more training. And that's certainly not, training has its place, and it is, one of the pillars, one of the foundations of our clinical practice, but it is not the go-to. In human factors, we design systems that support the behavior that we want. So it's really good to find people like yourself, Sue, who appreciate that and understand that expertise isn't just a consequence of training.
Yeah, and I am an educator, so, I'm very pro-education, but I also realise that having repeatedly done education over the years, sometimes it doesn't actually solve the problem that you have at hand. So I agree, some of our, we've got some great guidelines out there. We've also got some really good cognitive aids, which, I think we have to look at all aspects to give clinicians as much information as possible. We have got a very diverse group of clinicians these days, with a large number of clinicians who are going to be retiring in the next few years, and our younger generation of midwives are going to need to step up. So to have these to give them the skills and equip them with the tools to be able to provide the support they require is really important. So this is why it's important we understand how this works, so that we can actually translate that across into the next generation of midwifery staff and medical staff as well. Yeah. I think being in a tertiary facility, you and I talked a lot the other day around whether this environment actually is a good environment for our grads and students to actually train in. And I just thought I'd bring it into this discussion today, because obviously we talked a lot about it with around the human factors aspects. And I think you asked me a question around what did I think about that, didn't you?
That's correct. Yeah, I was asking you about how we typically see very high acuity cases, so labours and births, whether or not you think that that's actually helpful for our trainees, and whether or not it's a fair representation. We have, obviously there's a range of birth difficulties or birth scenarios, and they're only seeing sort of the pointy end or the sharp end or the most acute end of that. So how do you think that interacts with the learner's experience, and how do you think it impacts their practice as clinicians?
Yeah, that's it's also a difficult question. And I know we had some discussion and we thought we would talk about it today because I think it's in a very ideal situation. Really, our student midwives and our junior obstetricians should really experience normal and understand that normal. But because we have high numbers of students, we are in a large facility. In smaller facilities, it's much more easy to achieve. But in these sort of facilities, it's not so easy. And certainly my feeling is in those first few years, they should be exposed to those low-risk women in maybe midwifery models of care where they see that continuity aspect and see that normal birth process. But sadly, we can't always achieve that. We do try very hard, and I know the team leaders in situations try very hard to give our students a very rounded experience when they're on shift, but sometimes you have more students than you have staff, and they have to often be involved in situations which is way above the level they're at and can be a bit confronting for the students. And one of the biggest things from that is making sure that they work with an experienced person, and plus they get a good experience, that it doesn't come back as a negative experience. I'm going to share with you a situation I had a couple of years ago where I worked with a senior student who was in her final year, and we got allocated a normal labouring woman, which was fabulous. And but this student was completely freaked out because we didn't have a monitor on, and the woman was low risk and didn't need a monitor on. And because she'd been so used to that, it actually made her very uncomfortable. And this lady had no pain relief either. So it was a completely different concept, but she'd got all the way through her training to be facing this in her final year, which it saddened me to some extent because I felt, how is she going to be a midwife if she can't actually look after the woman in the normal situation? I'm also a great believer in that midwives in that normal situation don't manage women's labour. We guide women through labour. We might manage a labour when it's not going through a normal pathway. But certainly in the normal situation, you're the guide, you're the person who keeps it safe. And we do that in all situations. But I hear midwives saying, we managed the labour. And I think, well, you didn't actually. The woman did it with your help. So I think it's very important that we actually keep a check on what our students are doing so that we build their foundation blocks so that they come through this with a very broad experience. You and I talked about learning things for expertise, and I talked to you a lot about cues and how we act on cues. And I think you gave me an example. Was it a firefighter's cue?
Yes, it's a very famous study that was done by Gary Klein, and they were looking at expertise of firefighters and how they made decisions during very high acuity events. So they're in the middle of a fire, they're sensory deprived with their suits on, and how they make their decisions there. And so they were doing detailed interviews to uncover their decision-making processes during fires. And there was one firefighter that they interviewed who had said that he had made this decision. What had happened was he'd gone into this fire and at some point just had a feeling, he said it was like ESP, and made the decision to get his team out of that situation. And moments later, the floor actually where they'd just been standing collapsed, and they would have all ended up in the actual heat, the heart of the fire, and wouldn't have survived that experience. And so getting him to understand, and sort of in the process of interviewing and going through each of the steps of the judgment and decision-making process, it was actually that it wasn't ESP he was quite disappointed to learn, but it was actually reading environmental cues based on his experience. So, for example, there were things that were atypical about that fire. They had made the decision that the fire was ahead of them in the kitchen, but in actual fact it was underneath them. And so there were things that, in retrospect, he was able to say, well, yeah, the heat wasn't coming from the right location, and it was very, very quiet, and it shouldn't have been as quiet as it was. So I think the take-home message of that story is that our expertise is sometimes so implicit that we can't actually explicitly state what we know about a patient, or in this case about a fire. It's until we actually, go through a guided recollection of events to understand that our expertise is actually working for us in that case.
And I think that's a really good example. And certainly in midwifery, we talk about it being an intuitive job. And the more time you spend with a woman, you actually watch them, particularly when they've had no pain relief, how they behave in labour. And examples are, I often say to students, you need to get ready for this lady. She's going to have a baby shortly. And they'll say to you afterwards, how did you know that? And you believe it's because you're very in tune with a woman, but it's in fact exactly the same as that firefighting situation. situation, I watch behaviour, I watch the way people change. I've spent so many hours with people. You can see that change in the woman that the students or the new graduates have not quite tuned into. So I think that's a really important factor to get across to our midwives, that midwifery means with women. So you stay with the woman and you watch and you learn and you develop your skills. You don't have to be doing. Sometimes sitting quietly in the corner is the way that you actually learn how to be a good midwife. And that's things I've learned over the years, which I think, I can impart to the listeners today, which I think that firefighting one is a great one because it's exactly the same, but just a different context. Just changing direction a little bit now because, again, we've talked a lot about sort of labour and something I'm really keen to do is we do a lot of intervention in our labours and births these days, which is often very necessary because we do have high acuity. But, in my experiences, sometimes we call it the cascade of intervention. Once you do one thing, it leads to another. And something that's not uncommonly seen is that we have a lovely low-risk woman who's labouring at home and we invite them into the birth environment. They arrive and their contractions slow down or even sometimes stop. And of course, then they're open to us intervening because suddenly it's all gone away. And what do we do? Do we do anything in this situation? So I'm just thinking about, what can we do in that space, do you think, around helping these women to get back on track? There's those sort of situations where you look at the environment, for example.
I'm going to flip this one back to you, Sue Hampton, and say, as the expert, what do you think we can do?
Well, I think environmental issues are a big thing. And I know we touched on that right at the very beginning this morning about looking at our systems and our processes and how we do things. And sadly, probably, is that we are in a hospital. And hospital birth is the way people give birth these days. And so we've become very clinical. So to try and make something a bit more like a home-from-home environment may be something we need to look at, but we do need that clinical space. So it's really, as a researcher, I'm sort of thinking, how can we improve that for the people, for our consumers who are coming through the door, to improve their birth experience?
The way I would approach something like that, Sue, would be to go in and spend time really embed in the environment. So as a researcher, non-clinically trained, I think it's important for me to go in and do some ethnography of the actual environment. And so as an outsider, I can have so there's assumptions that you carry with you that I don't have, things like, well, we've always done it this way. If it doesn't make sense to me, then good chances it doesn't make sense, And so embedding myself in that environment and getting to understand the process flow and the procedural flow and the requirements of the task and the requirements of the consumer and the clinicians as well. And then looking at the ways that we can improve the design of the system to support and make it easier for clinicians and for our consumers as well to be in that space. And I think that's where the user-centered design process really has its strength, is that you're coming in at not as the sort of the expert on the white horse, but rather you're coming in as a naive expert, so someone who doesn't understand what's going on. And so you're asking questions that seem obvious to everybody else and understanding the way that things need to be and what outcomes we're trying to achieve by certain processes. And sometimes there's, more efficient ways or more supportive ways to get from point A to point B that we don't recognize because we have all these historical decisions in place that affect process flow.
I hope you realise from today that there's probably going to be a load of people wanting you to come in and go and sit in a corner and watch what we do, because we don't do that very well. We just literally adopt things and we put them in because we think it's right. But I think that fresh eyes approach has always been something that we look at from a day-to-day basis anyway. But this is a really interesting way of looking at it. I think we do it as clinicians, but I think bringing in someone with completely no contact with that clinical space has a very different way of approaching what is actually happening. It's amazing. It's just something that has always sort of made me think, how could we improve this? Going back to the simulation education and the difficulties for people having doing immersive simulation, and I obviously I teach it, so I feel it's very important. You think that simulation and immersing people in simulation or in situ sims is really useful for this sort of thing, or for emergency training? Do you think that we actually get a lot from that?
So I think that, there's a lot of value in simulation-based training. It's the only way really that we have to practice the things that we need to be able to do in a clinical environment. And sometimes there are issues, as you mentioned earlier, about buy-in and whether or not it does actually approximate a clinical environment, whether or not the validity is there. But it is the safest way that we can practice, and there's no potential really for adverse consequences or outcomes for our patients. The other thing about simulation-based activities is not just for training, but we can also, as I mentioned earlier, doing the process flow and testing environments and testing the way that we deliver care can also be very valuable.
That's great. So that could help us with our redesign of how we get our environment better, probably, by
Absolutely.
doing things around that simulation.
For sure.
Yeah, certainly trying to run things in situ would help us for sure. Okay, well, I'm very conscious of the fact that we've been sitting here talking very openly for the last sort of 20 minutes, half an hour, and it's been really interesting. So maybe from today, what sort of key take-home messages do you think we could give to our listeners today, Mia, from what you've been saying?
Well, I think importantly, it's about understanding that sometimes what we consider a clinical problem is a clinical symptom. And so doing that thorough problem identification, and it's really good if you can get someone who is used to taking a systems approach to solving complex problems in a healthcare environment. That's also going to be a beneficial way, I think, to move forward. I think also making sure then that we provide the solutions to those problems in a way that is very much user-centered. So not just coming in with a solution, but allowing that to be an iterative process that is informed from multiple different perspectives. And I think that understanding that the designs of our clinical space, our equipment, our tools really needs to be informed by human factors. And just remembering too that exposure really helps with expertise. It's not always training that's the answer to everything. And also that, you don't become an expert overnight, that it does take time. And I think being patient with that and I think too for our more experienced clinicians to just be patient with our junior clinicians as they're learning those cues and things that are the intangibles that create expertise that are difficult to explicitly learn.
Can you guide people to any, good reading or some excellent literature that they might think would be useful for them to have a look at? Yeah,
well, I'm biased towards the cognitive and the judgment decision-making things. So any work by the Daniel Kahneman, or Gary Klein, Laura Militello. There's a great podcast called Naturalistic Decision Making, which is fantastic to listen to. There's also there's some resources that I can put up on the website that will of journal articles and things for people to refer to.
That'd be fantastic. So just in summary and a bit of a recap from our discussion today, we've discussed human factors in healthcare, why research in human factors can change the way we deliver healthcare to our consumers, how we're affected by emergency situations, how we guide our staff to be able to cope with these challenging situations on a day-to-day basis. And we've talked a little bit about, how we respond, how our environment makes us feel, and some readings, etc., and why simulation really does help us, even though some people find immersion and doing simulation really quite challenging and difficult. If you would like any more information, please go to the show notes or visit the episode webpage. We also have the Maternity Education Program website where you can look at all our resources which are available for you, and also visit the CSDS website. Thank you.